Okay, so does it matter when we give our hCG? Most of us argue that in an FSH stimulated cycle, we're going to give our hCG around 16 millimeter follicles. So in this paper, they did 16 millimeter. They gave hCG, or they gave hCG at 18 millimeters, and again with the idea that which is better, when is the most appropriate timing. At the time of hCG, so early hCG is when they gave it at 16 millimeters. Late hCG is when they gave it at 18 to 19 millimeters. What they was a greater percentage of the follicles greater than 14 millimeters. And when you looked at whether or not there were 3 or more follicles greater than 14 millimeters, there were definitely more follicles. If you waited another 2 days, that's pretty much common sense. We're going to stimulate for an extra 2 days. We're going to get some more follicles. But there was no difference in the pregnancy rate. And surprisingly to me, there was no difference in the premature ovulation. So, we tend to want to trigger early. We shorten the follicular phase so that the patients don't ovulate on their own. But what this study is showing, at least on the patients that are getting FSH, they're not very likely to prematurely ovulate. Although 20% is not a small number. No difference in the pregnancy rates, whether they gave the patients hCG early at 16 millimeters or late at 18 millimeters. And no difference in the rate of multiples. In fact, they had the only multiples they had were 2 sets of twins that occurred in the patients that got hCG at 16 millimeters. So, as I kind of alluded to earlier, all of this is really we're basing so much of our decision making on our ultrasounds. And in our practice, we do, about 1,000, 1,200 cycles. And when we do in our IVF, and we're doing, several thousand IUI cycles, so we really have to rely on our very busy ultrasonographers. So we decided we wanted to go back and look and see how reliable are they. So we took patients that were hyperstimulated that had at least 9 mature follicles, and we had them get scanned, and then we brought them back to have the same ultrasonographer scan them about an hour and a half to 2 hours later. So they shouldn't have gotten significant growth in 2 hours. We wanted them to be rescanned to see how reliable our ultrasonographers are. These were both ultrasonographers and physicians one physician and 2 ultrasonographers that were participating in this trial. And what we found was that there was about a 1.5 centimeter mean difference in their own measurements. So again, in the radiology world, 1.5 centimeters would not be considered pretty significant, but 1.5 centimeters is really the difference between a 16 millimeter follicle and an 18 millimeter follicle. And so it really made us question whether or not we should even be relying so much on our ultrasonography. So to summarize this first part of this talk, what we know is that large follicles are more likely to result in mature follicles, although small follicles will also give us mature follicles, and 15 millimeters at the time of retrieval is the most likely to give us a mature follicle, 15 to 16. That multiple follicles retrieved do create bias. So when we look at pregnancy rates from these IVF, we know that we're getting a lot of follicles. We're selecting the best embryos. Maybe it's really not the best way of extrapolating data. All right, so now we're going to talk more about, basically, so this says the problem with our accounting firm is that 10 out of 5 accountants can't do simple math. Really, this is just numbers, right? This is, all we're doing is playing with numbers. And we all know, anyone who's done statistics, numbers can show anything that we want it to show. So here's a meta-analysis on whether or not we should be using IUI, whether we should be using hCG at all. This was done in 2007. It's based on, 7 studies, over 1,400, over almost 3,000 cycles that went into doing this study. Here on this meta-analysis, we have, I have no pointer, huh? Is there a pointer? Whew, I found it. So on this meta-analysis, we have, this is the patients that did, all these studies were comparing patients that used ovulation predictor kits versus being triggered by hCG. They were a combination of randomized controlled trials and prospective trials, but We looked at control trial. Those that favored LH ovulation predictors are here on the left. Those that favored giving hCG are here on the right. And you can find that in all of these trials, not a single one of them had statistical significance. So none of them showed a benefit of hCG injections over LH. When you combine the trials, and what the authors here did was assure that they were able to get the raw data from all these trials so they could comfortably combine the trials. And when they did that, what they found was that there was a statistical improvement in cycle outcome and pregnancy rates when the patients were using an ovulation predictor kit as opposed to those that were using hCG. Cochrane database did a similar analysis. These are only randomized control trials. In the Cochrane database, they flipped it. So here LH is on the right and hCG, so ovulation predictor kits are on the right and hCG is on the left. And they did not find a statistical benefit, although there was a trend favoring the use of ovulation predictor kits over hCG. So basically what we can say from this group of studies is that we rely a lot on our ultrasound to decide when to give hCG. We're increasing the money to the patients by doing that. Our ultrasounds are not particularly reliable, and there seems to be no benefit to using hCG anyway. Well, what about the timing for the IUI? Because maybe we should have a benefit there. And this is something we've all learned in medical school, right? We know that the most likelihood of having a conception is when the IUI is performed right in the pre-ovulatory period. And we are taught in medical school that when we do, that sperm will live for 3 days, but we know that sperm is living for 3 days in the cervical mucus. It's hard to know whether or not that's truly relevant to IUI. So we want to try to get our IUI as close to that window of ovulation as possible. So the first question is IUI even beneficial? IUI, this is a number of outcomes, and what we see is that in our control group, our randomized control group, they had this is unexplained infertility. Doing nothing, they had a 4% pregnancy rate. Doing an IUI alone, they had a 4% pregnancy rate. Using Clomid without an IUI, they had about a 6%, almost 6% pregnancy rate. But when you combined Clomid and an IUI, it increased their pregnancy rate to 8%. So that they doubled their pregnancy rate by using a Clomid and an IUI. When they used hCG alone, they had about 8%. But when they used hCG with an IUI, they had a pregnancy rate of about 17%. So I think we can argue that IUI is beneficial, again, with that concept of more sperm, more eggs, hope something hits something. So when should we give the IUI? So I'm going to show you 3 of my favorite studies. The first is from Tonga in 2010. And what they did was they looked at 3 time points. They looked at 24 hours. They did a double IUI, one at 12 hours and one at 36 hours. And then they did a single IUI at 36 hours and combined the outcomes. So the concept here is 24 hours is great because we can have the patients in the office. We see that they're ready to be triggered. We can give them a shot right there in the office. We don't have to worry about them taking it at home, and then bring them back the next day and do an IUI. So we get that kind of control. 12 and 36 hours is using that time of sort of mimicking what we would do with an LH kit. Although these patients received hCG, right? So if they test in the morning and we do an IUI in the evening, and then the following day we're looking at 12 and 36 hours. And this is what we do in our practice. We do our IUIs. We're not the doctors. I mean, we do our ultrasounds. The doctors aren't doing them, so we review our results in the afternoon, tell them to take their shot at home, and then bring them back 36 hours later. And basically, while there seems to be a trend to a benefit of 36 hours, these data based on over 450 cycles is not statistically significant. So Raman did a similar study. This is based on 600 cycles. They didn't do the middle time point. They looked at 24 hours and 36 hours. And again, that trend is reversed. Again, neither of these data are statistically significant. So based on these first 2 studies, you can argue 24 hours versus 36 hours. It doesn't matter. Whatever is more convenient in your center. And then the final studies randomized patients to 33 hours and 39 hours. And again, the 39-hour time point there was put in that we have our patients take their injection at nights, and some of those patients are going to have a problem. They're going to hit the plunger by accident. They're going to spill their medication. They're taking their injections at a time when all the pharmacies are closed, and so if they do have a problem, they're kind of screwed. So what can we do? Well, what if we waited for the morning and had the patients take it the next day? So we can still review our results in the evening. We can still make our decisions in the evening as to whether or not the patients take hCG. But instead of having them take it that night, have them take it in the first thing in the morning and do our injections at 39 hours. And again, no statistical significance. So based on these 3 randomized studies, now looking at, let's see, over 1,500 cycles, you could say it really doesn't matter. As long as you're within the window of ovulation between 24 and 39 hours, it doesn't really matter that much when you do your IUI. There's been a lot of studies that have looked at single versus double IUI. And again, have shown absolutely no statistical differences whether or not you did a single IUI or a double IUI. Admittedly, in our practice, we do a lot of double IUIs. When we use Clomid, we don't use hCG oftentimes in our Clomid patients. We have the patient's ovulation predictor kit, and we do an IUI at 12 hours and 36 hours after having a positive test. And that's, again, with that idea of assuring that we're doing an IUI at the time relative to ovulation, but the data suggests that really is not beneficial and is just increasing costs to patients. So in summary, combining IUI with OI does improve patient outcome. IUI should be performed within the implantation window, but it doesn't, as long as it's within that implantation window, it really doesn't matter what time. Specifically, we stress our patients, we tell our patients it needs to be within 36 hours. We shouldn't do that. There's no advantage of 36 versus any other times within that window, and there's no advantage to doing multiple IUIs. So in conclusion, the use of hCG may not improve outcome. It does, the Clomid patients will spontaneously ovulate, and so I don't find a significant advantage to using hCG in these patient populations. However, a significant number of patients that use FSH may not spontaneously ovulate, so we do look at using hCG. We will continue to use hCG in that patient population. It does significantly increase costs, and that's something to discuss with your patients. Follicular monitoring alone may not be adequate to determine the ideal time for hCG timing. All of these studies I presented really just looked at follicular monitoring. But what about using an estradiol level to help increase the reliability of your follicular monitoring? We spend a lot of time, probably too much time, looking at the endometrium and determining trilaminar appearance, hypoechogenicity, and use that to base our decision making for hCG. That's a whole talk in itself. I can tell you I don't believe that any of that matters either. And that single IUI should be performed within the implantation window.